So I'm a thoracic radiologist from the University of Pennsylvania. I'm also a researcher. So I will present a different perspective. The goal of this talk is more to inspire and to present the problem from the perspective of a physician rather than to present actual data or experiments. So the title is basically the synergistic role of advanced medical imaging um, in computer science, empowering medicine in the global fight against COVID-19. As I said, I will try to present the problem from the perspective of a physician, a radiologist who is in the front lines reading imaging studies on COVID-19 patients, but also a scientist that has some interest in AI-related research. I will discuss the role of chest radiograph and chest CT in COVID-19 differential diagnosis and management. And finally, I will propose a framework in which the medical imaging research community can work together with physicians to enhance the value of medical imaging in the global fight against COVID-19. So we all are very familiar with the challenges related to COVID-19. It's certainly the most serious global health threat since the 1918-1920 influenza pandemic. It has brought worldwide economic recession, immense human suffering, substantial loss of lives. And one of the problems of this disease is that it's a highly contagious respiratory disease that can be transmitted by respiratory means, droplets, and also fomites. And also, the majority of patients are post-symptomatic, meaning that they have no symptoms or mild symptoms while still able to infect others. And while we know risk factors for poor outcomes, the clinical course is difficult to predict. So that brings the question of how to best allocate limited resources that we have. For example, who needs hospital care? Who needs ICU admission? We all know pathogenesis of this disease. I'm just going to briefly talk about this. We know that the virus uses angiotensin convert enzyme type 2 receptors to enter human cells. That basically allows the virus to access a wide variety of tissues in the body. For example, pneumocytes in the lung, respiratory epithelium, renal, GI epithelium, and the vascular endothelium. And that tells you a little bit about what it can do in the body. There's a very wide spectrum of illness severity. About 80% of the patients have mild or asymptomatic clinical courses. 15% are severe, and up to 5% have critical conditions that can lead to death. 95% or more of the patients develop symptoms within 10 days. It's very important to have this time frame in mind because whenever we get an imaging study, it's important to know when the imaging was performed relative to the onset of symptoms. The median time from onset of dyspnea, which is shortness of breath, to hospital admission is about 7 days. And we know the risk factors for more severe clinical presentations, older age, multiple comorbidities, immunocompromised status. We also know that pneumonia is the hallmark of severe and clinical presentations. And in patients that have critical presentations, ARDS, oftentimes associated with cytokine release syndrome, is a common condition. So what's the role of imaging? We know that the definitive and the confirmed diagnosis of COVID-19 requires a positive PCR test for the virus. That's obtained via a nasopharyngeal swab. We can also test for other respiratory pathogens. And we also know that a positive PCR has a very high positive predictive value, which means that if you have a positive PCR, generally you have the infection. There are very few false positives. But we also know that the false negative rate is not that low. It can be between 20 to 50%. That also depends on the technique in which the sample is acquired, depends on the type of system that you use to identify the virus. So that may require us to do serial sampling in many situations. And we do that quite often in our hospital. That's something we have to emphasize. A negative chest imaging exam does not exclude infection with SARS-CoV-2, right? The other important consideration is that chest radiograph is the primary imaging modality in most countries, although some countries have used CT more liberally, even though chest radiographs are not sensitive and are not specific for the diagnosis of COVID-19 associated pneumonia. CT should also usually be reserved for complex situations and more in problem solving, especially when you're looking for differential diagnosis. What else could be explaining the patient's presentation? Any contributory factors, any reasons for clinical deterioration. The Flagellation Society issued a recommendation recently, April 2020, in radiology, in which they basically try to provide some guidance in terms of what and when to do imaging examinations. Their first observation is that imaging is not routinely indicated in suspected COVID-19 with mild symptoms, and that comprises about 80% of the patients. Once a patient has respiratory symptoms, especially worsening respiratory symptoms that require hospital attention, then imaging is indicated. And they specifically say that if you happen to basically live in a resource-constrained environment, for example, if you have a lack of enough PCR tests, then imaging can be used for triage of patients with suspected COVID-19, especially if you have moderate to severe clinical features and a high pretest probability, means that you have a high incidence. And a high incidence of COVID-19 is essentially a global problem nowadays. Many countries have a very high incidence presently. So chest radiograph in COVID-19 should really be the primary modality. And most patients, as I said, have either a normal chest radiograph or they have findings that are unrelated to COVID-19. And we also know that most symptomatic patients will have pneumonia at some point. The chest radiograph is not very sensitive or specific, and there's a significant overlap with other infectious etiologies and also other non-infectious conditions. The hallmark of COVID-19 is basically when in terms of involvement of the lung tissue, the lung parenchyma, is bilateral airspace disease, typically multifocal, which is essentially pneumonia, a viral pneumonia. And also it's important to observe that it's not uncommon to have findings that are potentially related and findings that are likely unrelated to COVID-19 coexisting in the same patient at the same time point. So CT basically is, as I said, more sensitive, more specific. There are typical patterns that are suggestive of COVID-19 in the appropriate clinical setting. For example, when you have acute ground glass opacities that may or may not be associated with consolidations and interstitial thickening in a distribution that is multifocal and bilateral. And I will show some examples. It's more sensitive and specific than chest radiograph, but still, there are numerous differential diagnostic considerations that we have to entertain. It's also important that to realize that no CT findings can confirm or exclude COVID-19 with certainty, which means that the imaging findings are not pathognomonic, which means that there's always a differential diagnosis, even if the findings are typical for COVID-19. In order to maximize the utility of CT, one needs to assess the following. It's very important to know the clinical context. So what are the symptoms? What's the date of a symptom onset relative to when imaging was obtained? You always have to think about alternative explanations, comorbidities, the pretest probability, which basically refers to the current prevalence or incidence, in this case of the disease, of COVID-19, where you are. And then you also have to think about whether the findings are acute or chronic. And all of those observations should guide any effort to develop artificial intelligence algorithms to basically look at imaging patterns. So I show this example, which is a real case. That's a patient that we saw in our health system. And you can see that it's a high quality PA lateral chest radiograph that's absolutely normal. This patient had 2 days of fever and dry cough when this image was obtained. The patient was tested because there was suspicion for COVID-19 and the test came back, the PCR came back positive. So the patient was diagnosed with COVID-19 with a normal chest radiograph and was sent home for self-quarantine because he had relatively mild clinical presentation. But then I'll show 2 videos of what happens a few days later, and that's quite common in many patients. So for example, he came back day number 6 with worsening shortness of breath. And now you can see a very typical pattern of COVID-19 associated pneumonia, multiple rounded and peripheral ground glass opacities bilaterally with basal predominance. This patient was admitted to the hospital that day, and then eventually needed ICU care, and that's the CT that you see 14 days after onset of symptoms. And you can see that the pattern is similar, but it's much more severe. There's more extensive airspace disease, which is basic ground glass consolidation. The percentage of lung parenchyma involvement has increased, and the density has increased. This patient is much more symptomatic at that time. I'll just move forward. So that's another patient. There's a patient who has an underlying um, predisposing condition. The patient had bilateral lung transplantation, so the patient is immunocompromised. And you can see that this is a baseline scan done several months before. There's not much, but just areas of scarring in the lung bases. And then this patient comes with 6 days of cough and shortness of breath. And now you see faint, small areas of ground glass opacity. Okay. And this patient was admitted to the hospital because of high risk due to lung transplantation, was tested for COVID-19. We confirmed the diagnosis by PCR. Day number 22, the patient is much worse, is in the ICU and has ARDS. This patient is intubated now, and you can see that the extent and the severity of ground glass opacity has increased. There's more involvement in the lung parenchyma, but the pattern is similar. It's just more severe with a greater percentage of the tissue involved. There's another example of a patient who also has a predisposing condition. This patient had a lymphoma, which is a hematologic cancer. And this is a baseline scan that is essentially normal 3 months before. And then the patient comes to the hospital, day number 9, with fever and respiratory symptoms, cough and dyspnea. And you can see that at this time, there are new areas of peripheral consolidation and ground glass opacities. This patient was tested and the PCR was positive for COVID-19. So that's another manifestation of COVID-19 associated pneumonia. And it's important to basically always, when you have a chance, to basically go back in time to see if the findings are new. Chronic patterns are much less likely to be able to COVID-19 than acute patterns. So that's very important. And again, this should interfere like the way we think about AI algorithms. This is a patient just to show you a more complicated situation. So this patient has metastatic breast cancer. And then she had the baseline scan that basically show small nodules. So you can see those nodules are basically solid, which means they're dense, but they also have areas of cavitation. Those are metastatic lesions. And then the patient came back with 3 days of cough, fever, and worsening dyspnea. So of course, the possibility of COVID-19 was raised. The patient was tested. And we saw some like faint areas of that I'm showing here, ground glass and twin budge nodules that basically indicate bronchiolitis, which is an inflammatory condition. But the test came back negative for COVID-19. And the patient was positive for another virus, which is a rhinovirus. Just to show you that the differential diagnosis always have to be considered when you're basically evaluating those patients. The patient also had pulmonary embolism, which is another potential risk in COVID-19 that can also lead to increased morbidity and mortality. There's a hypercoagulable state that we are more aware that this is a complication of COVID-19, and that's something also we have to basically think about when we deal with this disease. So that's the last case I'm going to show you, just to show you a pattern that's not likely to be COVID-19, even though it's an acute airspace disease. For this patient came with a chest radiograph, and you can see that this chest radiograph was done day number 7 after the onset of cough and fever. And there is like a dense airspace opacity, a consolidation in the left mid-lung. And you see that on CT, it's a left upper lobe consolidation, it's focal. Focal consolidations are not likely to be related to COVID-19. But the patient was tested, the test came back negative, PCR for COVID-19. Also, we did a respiratory viral panel, we also came back negative. This patient tested positive for a bacterial infection, a Streptococcus pneumoniae, which is a very common cause of bacterial pneumonia. The patient was treated, and you can see the chest radiograph performed 4 weeks later is completely normal. So this resolved with antibiotics. So in summary, I presented all these examples to show you the spectrum of COVID-19 associated lung disease, and also to show you that there are many situations in which it's much more complicated than just trying to detect airspace disease, because the patients may have pre-existing diseases or may have other conditions that are chronic and are not related to COVID-19, or the patient may come with a different type of infection. And there's some association of specific imaging patterns that I described with COVID-19. So the chest CT findings in the appropriate clinical setting, they are sensitive and they're model specific for diagnosis of COVID-19 associated pneumonia, but they do not replace the PCR. The PCR is the definitive test to confirm the diagnosis. Chest radiographs and CTs are very helpful to evaluate differential diagnosis. and also any other factors that may be contributing to the patient's overall clinical presentation, risk for clinical deterioration, and potential for like a poor outcomes, such as death. Chastity helps management in complex scenarios, especially when we have clinical deterioration. And here's where I'm going to basically propose a link to research ideas in terms of like how to tackle that, utilizing AI, artificial intelligence algorithms to analyze medical images, chest CTs and chest radiographs. I do think that the value of imaging may increase once we apply quantitative algorithms, as long as we can focus on addressing questions that are meaningful. And I would say that the most meaningful questions are basically characterizing the type of lung abnormality, what's the pattern, right? Because we know that COVID-19 causes airspace disease. It does not cause, for example, well-circumscribed nodules or bronchiolitis or cavitary consolidations. So that's important to recognize. And then the spatial distribution also matters. This disease is almost always multifocal and bilateral. So if you see a focal finding, which is basically involving just one region of the lung, it's unlikely to be COVID-19 unless we image the patient very early, which is also why you need to know when the imaging study was obtained relative to the patient's clinical presentation. And then the last question is basically how much of the lungs are involved, because that's where you can draw a parallel with what you're seeing in the imaging exams and other physiologic biomarkers. For example, the patients like a saturation of oxygen or markers of systemic inflammation. And then if you do that quantitatively and you measure that over time, then you have what very well may become a prognostic biomarker. So that's a framework that I would like to basically propose for artificial intelligence research utilizing quantitative CT and also quantitative chest radiograph in COVID-19. That was a consideration that was also raised in the very elegant prior lecture, which that imaging findings must not be considered in isolation. We need to know, and that's why it's important to collect and organize data. We need to know the clinical context. We need to know the patient's like risk factors, comorbidities. We need to know how the patient is basically evolving, when the symptoms started, when the imaging studies were performed, and we need to know the laboratory biomarkers that are relevant. For example, markers of systemic inflammation, markers of increased risk of pulmonary embolism, markers of like a poor oxygenation, because that reflects physiology, but also impacts outcomes. Detection of airspace disease has a role in research-constrained environments for diagnosis of COVID-19. But we also have to remember that diagnosis will rely primarily on PCR, unless you don't have access to PCR, which is typically not the case in most countries nowadays. We may have not enough, but we do have, and that should be the confirmatory exam. Detection of like other types of diseases is relevant in the sense that it changes the patient's risk for poor outcomes. It's different if you're a relatively healthy, young patient that does not have any known or pre-existing condition, or if you do, in terms of like your risk of like a poor outcomes. And that's been shown in multiple published like papers that age and comorbidities are risk factors for like poor outcomes, including death. So, and also, I think it's important to take a holistic approach to quantitative chest radiography and quantitative CT. Again, trying to identify not only the patterns, but also thinking about ways to characterize the spatial distribution, the extent of like a lung that's involved by the COVID-19 related disease patterns, and also the temporal evolution, whether the findings are acute or chronic and how they're changing over time. So that brings me to my second proposal, to basically how we can create a framework for AI-related research utilizing quantitative CT and quantitative chest radiographs for prognostication, which is basically to try to predict how patients will evolve, so we can allocate care in a more proactive fashion. For example, we can preempt the deterioration. If we know that a patient will likely have a poor prognosis, there's no reason to send this patient home. We may have to keep this patient in the hospital from the very beginning. We may have to be more aggressive in our interventions. And then now we're having multiple clinical trials going on for medications. We're going to have trials for vaccines really soon. We also have to have a way to basically assess the effectiveness of those medications. And that's another opportunity for quantitative imaging research. So longitudinal assessment is crucial. Those patients are imaged typically at multiple time points. We're getting many more chest radiographs than we're getting chest CTs. But once the patient is in the hospital, we expect to see chest radiographs on a daily or semi-daily basis. So it's important to basically be able to look at whatever we are measuring. And if we measure, for example, the burden of airspace disease, we're doing that in a longitudinal fashion and correlating that with like other clinical and laboratory biomarkers. It's important to, again, differentiate. This approach is important because it differentiates acute disease from pre-existing chronic findings. You will offer potentially a quantitative CT or even a quantitative chest radiograph derived biomarker that may be helpful in prognostication. And I think that once we have that data, that becomes another element to inform statistical predicting models that can predict not only prognosis, but also therapeutic response. And I think that would be a major scientific contribution and a medical breakthrough in this pandemic. And finally, we have to always think about those three components: severity, change, and velocity of change, right? So severity basically means how much of the lung is involved by the patterns that are likely to be related to COVID-19 that we discussed before. How does it change over time, and how fast it's changing over time? So my last slide conclusion is basically that I do believe that artificial intelligence, computational imaging analysis, and medicine can work together in order to maximize the value of the information that's present in medical imaging, as long as we're able to address questions that are meaningful and relevant. Diagnosis of COVID-19 is crucial. And diagnosis with imaging is a part of the way, a part of the mechanisms by which we achieve a diagnosis. PCR is still going to be the cornerstone for diagnosis. But not only the diagnosis of COVID-19, but also diagnosis of like other conditions that may explain the patient's clinical presentation. Without accurate diagnosis and without taking into account the complexity of the patient, physicians are flying blind. And then there's less we can do to help patients. Prognosis is equally important because obviously, as we said, we have to basically be able to allocate resources in a wise, effective fashion. And also preemptively, I mean, trying to basically be more aggressive in patients that we know are more likely to deteriorate based on the results of those predictive models that we can build once you have those ideas and those tools. And AI and quantitative imaging biomarkers may really improve prognostication and evaluation of therapeutic response. And I think the ultimate solution to the COVID-19 crisis will come from people like us, physicians, researchers, who are basically trying to work with scientific ideas to help medicine such that we can have a final definitive medical solution. And I think that together we can win this war. So with that, I would like to thank you very much for your attention and open for any questions.